Okay, cardiology and cardiac emergencies. Quite a short lecture, but a very large topic. We'll get this slide out to people. This is everything that it says on my, you don't have it, on my color sheet in the other book. This is everything that it says over there, just written out a little differently. We always start off with a quick review of the anatomy. So, atria, ventricles, valves, vessels, oxygenated, deoxygenated blood. This is all review. You know all this stuff. We shouldn't have to go into this too much. All right, this is something that's new, and I'll just talk about this for a couple minutes. The heart works with by generating its own electricity. That's how the heart works. It generates its own electricity, and for that reason, it needs to have electrical conductive, we'll call them wires, they're really called pathways, but you need to have pathways that electricity can flow through the heart. The electricity does not flow through the coronary arteries, for example, or through any sort of blood vessel. They have their own special pathways. Let's talk about how the heart generates the electricity and how it works. Everything starts here. This is the right atrium, in case you weren't sure. And everything starts at the SA node. SA stands for sinal atrial node. You don't really need to know that. Just know it's called the SA node. And a healthy heart, from the minute a baby is born until the patient dies, the SA node is supposed to give an impulse, an electrical impulse, that will travel through the right atrium down into what's called the junction, where the atrium and the ventricles meet, and then branch off into these two left and right pathways.
Where's the junction?
Junction is at the bottom of the atrium, the top of the ventricles. Okay, it's known as the junction. These all have names. These pathways.
The SA is your igniter.
That's the igniter. That's like the starting pitcher.
Does that not work?
Let me get to it. The SA node is like your starting pitcher, standing on the mound and constantly sending fastballs. How often is he sending them?
Pulse.
60 to 100 times a minute, right? That is the pulse.
What's that from?
How that happens, that's chemical reaction that we don't need to go into in this class, okay? But that is what you need to know. It starts at the SA node, and the electricity travels down here to the junction. Okay? The junction has an official name. It's called the AV node. AV stands for atrial ventricular, right? Same thing. But you won't be tested on these things. This is just for your knowledge.
What does SA stand for again?
AV.
No, what does SA stand for?
Sinal atrial node.
What does
Okay?
that mean?
When you'll hear medics look at EKGs or doctors in hospitals, you may hear the term, it looks sinus, or it's a sinus rhythm. What we're saying to each other is, it's starting here at the SA node. So the word sinus comes from sinal atrial node, and when we look at an EKG, we'll be like, oh, it's a sinus rhythm. Okay? It's just a way of saying to each other, which is good, which is what it's supposed to be. Sinus is good, because it's supposed to start here, and we can see that on the EKG. Alright? Now, electricity passes through here, through the AV node, or the junction, and then splits into the right and left, and these are known as the Purkinje fibers, or the bundle of His. You won't be tested on this, I'm just giving you a brief introduction into electrophysiology of the heart. Okay? All the stuff that we see on EKG, when you become a medic, you spend 6 to 8 months learning how to read EKGs. All you're seeing is what is going on between here and here, between here and here. Okay? At the end of the day, this will cause the atrium to squeeze and relax, and these will cause the ventricles to squeeze and relax. So somebody asked, good question, what happens if it goes wrong? Does the SA node stop working or whatever? So yes, the SA node gets sick in certain patients. The SA node can get sick and not work properly. The SA node can get sick and not work at all. So Hashem gave us a backup system. In fact, there are two backup systems. One is the AV node. The AV node is a backup pitcher, like a relief pitcher. All right? And the AV node sees that, hey, no one's pitching. I'm not getting any impulse from the SA node, and it wakes up. And it starts sending its own electrical impulses, okay?
As soon as the SA node
As soon as the SA node gives up, it'll start usually going to the AV node. Now we can see all this activity on the EKG. The AV node, however, is not as good as your starting pitcher. He can do 60 to 100. He can only pitch at about 40 to 60 times a minute. Okay? So we're already going to see a bradycardia, right?
That's when he's on his own. Usually he's...
When he's getting it from him, he passes it through at the same speed he receives it.
Okay.
Just a
When
relay.
he's initiating it over here, he can only do about 40 to 60 times a minute. Okay? Now, when patients get really sick and the AV node gives up, okay, these fibers, the Purkinje fibers, which are at the end of the bundles of his, okay, they can actually fire themselves, and these patients are very sick. These patients will usually have a ventricular rate of about 20 to 40 times a minute, max. These patients are really sick, okay? They get pacemakers and, you know, all that other help. Certainly they need medics on the scene if you have patient that sort of bradycardia. Even the 40 to 60 range, you should be getting paramedics to look at what's going on. So, not much particularly you'll be tested on, but I think it's very important that every EMT has some sort of idea why the heart is beating and how it is beating, okay? Going into all the chemical reactions is extremely exciting and great knowledge, and understanding about the sodium, potassium, and the potential, the change in potential, and all the stuff, how it works. You got to go to medic school, and we'll teach you all that stuff. But not right now. Right now, I just want you to know there's an SA node, the AV node, and then it fires down into the
But
ventricles.
for the most part, whenever a person...
Healthy people starts up here.
But whenever a person is having a cardiac...
I didn't
issue,
talk
it's
about
usually
any
because of this?
problems. No, absolutely not.
Okay, that's...
This is the electrical pathway.
Because we always have the thing with the AED, which is what...
Where does it go after the bundle
It dissipates into the ventricles. And then, and then it starts again. It's used up. Okay?
So you're saying, like you said, when a person sticks a fork into the electrical...
Yes. It can mess up their electrical system. That's what can get messed up. Yes, absolutely. Electrical burns. All right, so this is way more important that you need to know as an EMT, and that is to talk about the coronary arteries, right? We've mentioned them before. Let me just recap so you all understand what they are. The heart has 4 chambers. Blood is constantly coming in and leaving, going from one to the other, back to the lungs, to the body, back from the body, to etc. But none of that blood perfuses the heart. We've spoken about this before. The heart muscle, being a muscle and being in the body, requires perfusion.
Just like everything else.
Like everything else. How does the heart get perfused? So the answer is right here. As soon as the left ventricle sends blood up into the aorta, remember this number 1 is the aorta. Soon as blood gets sent up into the aorta, the first arteries
Fresh blood.
that will get the blood are these
Pulmonary artery.
coronary arteries.
Coronary.
coronary arteries, and they carry blood from the aorta right back and give perfusion to the heart. You
Are they a higher
recording?
quality?
Don't record.
Me?
Yeah.
I'm looking.
Oh.
Are they a higher quality blood because they're straight out of the?
No. Same blood that you get anywhere else.
Okay, so
Okay, it's just the heart's getting right away from the aorta,
Is it a
right
lot?
from the left
is it a
ventricle.
lot, is it?
No, whatever it needs. Same amount. Okay? You do not need to know, you're not expected to know the names of the coronary arteries. You don't need to know where they are. It's on here just for knowledge, whatever. But you're not responsible to know that. You're responsible to know that from the aorta, right away comes off coronary arteries and they perfuse the heart. Okay? Here, some quick recap. There are 6 liters in the average adult. Okay? Preload, afterload, heart rate, stroke volume, all this stuff is, I really don't think you need to get into, or you'll be tested on in EMT school.
Should we cross that out?
No, it's all good stuff. Blood pressure, we know we have a systole and a diastole. That's translated into a systolic and a diastolic blood pressure. You're familiar with that? Perfusion is getting oxygenated blood around the whole body. Hypoperfusion, we know all this stuff. This is review, right, Shock? So we know all this. Good. Can you see this? I love this picture.
Cheeseburgers.
These are burgers floating around the blood supply. You see that?
Should be Izzy's.
Yes. So, this brings us to coronary artery disease. Coronary artery disease, or CAD, as it's sometimes known. What does it sound like? What does it mean? Coronary artery disease. Where's the problem? In the coronary arteries. What are the coronary arteries?
Arteries that supply the life.
Blood and oxygen to the heart. Very good. So when we have these cheeseburgers and other delectables, right, floating around in there, we can have 2 particular problems, okay? Now both these words are long words that begin with A, okay? 1, you need to know these words, is atherosclerosis. The other one is arteriosclerosis. Know both words. That's the hard part. The easy part is that the definition in EMT school are interchangeable. So either definition could be applied to either word.
You never get this answer wrong.
What makes them different words then, besides this?
Because they do have different definitions. But as far as EMT school goes, they're going to lump them together. Okay? So your answer will always be atherosclerosis or arteriosclerosis. What are they? Atherosclerosis, I put here, buildup of fatty deposits on the inside of the lumen. Lumen is the inside of any tubular pipe. Okay? And arteriosclerosis will be a buildup of salts, calcium, and loss of elasticity. What I'm telling you is that there will only be one of these answers in any possible question, and that'll be the right answer, if that's what it's talking about. Do you understand me? Is that clear?
Is there a reason why it looks like burgers there and hot dogs in here?
Yeah,
There's a hot dog and
Change his mind.
yeah.
Another question, why did these things affect the coronary artery more than any other artery?
Because they're very, very narrow. They're very narrow.
More than other
Yes.
arteries.
Change the pictures.
Yes.
Like today.
Yes. So, if we look over here, let's look at these three, look up here, look up here. We look at this is a normal, nice, open lumen of a coronary artery, right? Clear, everything can pass through, blood's flowing beautifully. Now, here we have some atherosclerosis. What's happened over here?
A little bit of
Fatty buildup. Can blood still flow?
Yes.
Yes, it can. Okay? Now, this patient may get angina from time to time. We'll learn what that is soon. Hold on. However, you can't really see because of the light, but right over here there's a blood clot and it's got stuck. Can blood flow now? No. This patient is having an MI, alright? Here is the spelling, acute myocardial infarction. We never say it, we just say MI, also known as AMI.
He's far.
Yes. Okay, here's a picture again of blood being able to flow and blood getting stuck. I guess I'm not quite sure. I think
Those
this.
are all.
You may have
they're all
to change
fine.
that slide.
Yeah. We'll try to do a little
A
Izzy's.
little better.
Put a little Izzy's in there.
Yeah, we need some Izzy's in there, alright? Alright, guys, the word you need to know, the word you need to know is infarction. And that here, you see the blackening here?
The bottom.
So infarction will always be distal to the blockage. Yes? Shraggy?
Shragi's heat lost, home lost heat, all heat. He had to transfer his family
Oh.
on double. 10-7.
Low stuff.
Yeah,
One
10-7
sec,
low.
how do you get to infarction down to the tissue? You lose oxygen?
Yes, yeah, because look,
Oh,
when
I
once
see
this
the
clot gets stuck here and nothing can get perfused down here,
So anything distal.
anything distal to that blockage is going to die and cause
3 to
infarction.
4 minutes.
How long does it take to happen?
So infarction is death of tissue?
Death of tissue.
That's it.
That's it.
Will always cause what's the
But it's-
It's also known as necrosis. But we use for hearts, we typically say infarct.
what's it always gonna
Oh,
cause?
he was
infarction?
But it's because that region is deprived of oxygen.
Yes, yeah, one region is deprived of oxygen. Now, are they gonna drop dead in front of you that second? No.
But how long does
There's
No, this could take, we don't know how long
lack of
this
oxygen
will
for
last.
how long would it kill the tissue?
Oh,
That's
it
5
depends, it
minutes, half
depends
an hour?
which artery is blocked. If it's a huge big pipe,
Oh, it
or if it's one of the
Anything
tiny
distal.
little ones,
Distal.
no way,
Anything
no way
distal
to
to
know.
that artery starts to die.
Yeah.
But
Yeah.
how, that's what he's asking, how long?
But there's other circulation getting to similar places from other
okay.
arteries,
Oh, okay.
remember?
Right.
We're not usually talking about one of the big ones. It's usually a branch of one of the big ones.
But it would affect that little area too, no
Sure,
matter what.
distal to it, yes.
So,
Anything-
Distal to that, but it may branch off into other,
and they would be
Small.
getting from other places.
they'll get it from there, yes.
Gotcha. But in general, it's about 3
As
to
you get
4 minutes,
older,
no?
you actually grow, this is not really for this class, but you grow more coronary arteries and you produce more, and there's a whole lecture about that, how it will, as you get older, you have actually, a way to compensate for these
So the
things.
dead ones.
Well, no, not for the dead ones.
But they're not blocked.
They're not blocked yet, okay? Everybody get this?
Yeah.
Good. So acute coronary syndrome, ACS, same as CAD. Okay? ACS is a bunch of syndromes, but it's really the same as acute coronary disease. CAD is it. Don't worry about these. We don't use them. We don't use these expressions very much. Don't worry about it. This is what you gotta know. Angina pectoris. Okay? Angina pectoris is Latin for pain in the chest. That's it.
Pain
Okay?
in the?
Chest. Not neck or not anywhere else this
Sounds like a
time.
friend I know.
Right, he left, okay? Angina pectoris, alright, is a pain in the chest. Now, they're gonna test you a lot on angina, on MI, and knowing the differences between them, one thing and another. We're gonna get into it a little bit more tonight.
So could that be like heartburn?
No. It could feel like heartburn, but it is not like heartburn.
So how do you
No.
know the difference?
Heartburn is a GI problem. That's a belly abdominal issue. Angina is a mini MI that resolves itself. Okay? Meaning something gets blocked, but then they took a nitro, or they rested, or they got oxygen, or whatever they did, and the chest pain went away. They feel better. Okay?
So how do you differentiate?
Let's talk more about the signs and symptoms of an AMI, acute myocardial infarction.
Angina.
Okay? What happened?
Alright, now see, it says angina. I wasn't trying to spell, okay.
Okay.
Angina.
Only it's on this page, but okay.
No, I saw it.
Just got it.
Angina, and there's, and that's, and then there's a
no V.
mangina.
There's no V, yeah, there's no V.
No,
Okay.
okay.
You're not.
The chief complaint that people have, the number one complaint, signs and symptoms of the AMI, is chest pain. Okay? The call comes out for the patient with chest pain. It means nothing until you get there. Okay? I had a patient with chest pain. The EMTs called for medics. I come on the scene. The EMTs are just taking out the aspirin and wanting to give the aspirin. I'm like, no. You had your chance. I'm here now. No aspirin till I decide now. Now, it's all changes now because I'm here. Till I got there, you could have maybe given the aspirin. Now I'm here. Now I'm going to reevaluate everything. So the first thing I do is I say, you have chest pain? He says, yeah. I said, show me. Where is it? It's here. I said, this is your shoulder. I showed the EMTs. Shoulder, chest. No, seriously. Do you have any pain anywhere else? Yes. Where? Over here. I'm like, EMTs, chest, abdomen, right? Okay, so we're not even dealing with chest pain now.
And then you turn back to the patient.
Aspirin can help the shoulder pain also.
No, it's not. No, it's not what it's for.
Could it be referred pain?
No.
Doesn't happen that.
So it wasn't chest pain. It wasn't chest pain.
No, that's
Okay.
working too hard.
So
But that's an easy one, that's like, it's not the right body part.
yeah.
Well, let's.
So we need to ask them about this chest pain, right? We need to ask them questions. The most common, and this again, test question, most common way that they describe the chest pain is a huge weight on their chest. Some say like an elephant standing on their chest. Not quite sure how they know what that feels like, but that's how they describe it anyway. But definitely feels like a pressure. I have many patients over the years tell me, well, I don't really have chest pain, it's more of a pressure. I say, okay, now we need to worry. When they say that, it's always the big one, okay? When they say it's not really pain, it's more like a pressure, they're trying to play it down. What they just did was tell me they're probably having an MR, like full on, okay?
So a few months ago in school, I went to the EMT and I said, I'm having real pressure over here. So they brought me over to a medic, and the medic's like, he usually stays very calm, and once I said that, he's like, okay, let's take an EKG. But it really was just a muscular.
Right.
There's really.
He should have been able to have determined that.
We did an EKG.
Too much challenge?
Not from the EKG.
It's hard, I had to go to a cardiologist, I do a stress test, a nuclear stress test, and they said
Okay.
everything's okay with the heart.
I would have been able to have told you that it wasn't.
How?
People muster on the call, like the EMTs?
How?
In front of the patient.
How?
That makes them feel real good.
How would you have been able to tell by sight that it was a muscular?
Let me finish this. Okay? So chest pain, crushing chest pain, pressure. When they use that word pressure, I'd like to add that into the slide actually, the word pressure over here. Now, there could be referred pain, but for there to be referred pain, there has to first be chest pain. So very often there'll be chest pain, some are up here,
And then
and then they say, and it's like shooting into my shoulder, my jaw.
You heard that?
Left hand.
Oh yeah.
But
Typically
it's
the
only-
left side.
If it's only the other.
Yeah, then
That
it's
pretty much confirms.
if there's
that.
only
I'm saying
referred
it confirms
pain,
the
it's
MR.
not.
Right, only.
any of these things can help to make your diagnosis. They cannot confirm it because we need a lab and blood work to confirm it. But right, feeling of impending doom. I had a student called me about this just the other day.
It's horrible.
I wasn't on the call, but a student, one of my, I think, medic students told me that they had a patient who told, as soon as he walked in, I think I'm going to die. He said those words. So he asked the family, is this like the type of person he is? This is normal way of speaking? The family said, no, he'd never say these words. Okay? That is impending doom. He had a massive MI. That was his only real sign. Okay? So it can happen. I find though with Acheinu B'nai Yisrael, I find the opposite. I find them always playing it down. Denial of severity. Okay? I had a big cholent, I ate 2 kiddushim, I did that. There's always an excuse why they don't want to go to the hospital. Okay? I have numerous people that I saved their lives. They're alive today because I wouldn't leave their living room and I wouldn't accept the cholent excuse for the chest
You gotta
pain.
add that bullet. Child excuse.
Denial of severity.
So that's the opposite, that's the opposite.
Harry,
Complete
hashtag
opposite.
challenge excuse.
Child would help, you know.
Okay?
It should really be in the same line.
So-
you know.
Well, no, that completely opposite. The
I know.
complete opposite. Cool pound diaphoretic skin. All right. Now, someone should say, "Oh, but that's indicative of shock. Are they in shock?" So, you got to remember, in medicine, the same signs and symptoms can be for 100 different problems. Nothing is limited. Nothing. Okay? Except if your, tibia is sticking out of your leg, and it's not a humerus, right? But it's limited. But typically with medicine,
Why is it laughing?
because it was humoral. Typically in medicine, there is no sign or symptom that only belongs to this thing. However, we pretty much narrowed down constricted pupils to opiate overdoses. So, but I like to say there is no one sign or symptom that belongs to one disease or one problem, all right? So, cold, pale, diaphoretic skin, I've seen this many times.
Call it diaphoretic rather than clam.
That's the word I use. That's the more medical word.
Is there
Okay?
a time of
Diaphoretic means that they are wet and sweaty in a nice, cool, air-conditioned, or, they'll be out here and they're soaked
Sweaty.
from sweat. Okay?
Are most
That's
of your-
diaphoretic.
Are most of your legitimate MI calls in the morning, afternoon,
No
evening?
particular
No
time.
particular time.
Nothing cholent, but no particular time. No. It's a good question. I've never really done statistics on that. It's never been something that I thought about.
Never will.
I could look if there's any literature on it, but I don't have any. No, I don't have any data. Pain not alleviated with rest. Okay, the most common chest pain calls in New York City, I would say, are shoveling snow. I was shoveling snow and I couldn't breathe and I had this pain in my chest. I came inside and I sat down. Do you have any history? Do you ever had this problem before? No. Did you ever shovel snow before? No, because we haven't had snow for a number of years or whatever it is. No. Usually my grandson does it. Now I'm doing it myself. Whatever it is. Very common after physical activity. Why do you think that is? Well, it has to do with preload, afterload, and all that stuff, but how much blood return is needed to get back to the heart. And if there is a blockage, maybe a clot is formed and is now no longer letting it get through. So not alleviated with rest is definitely...
Because you didn't
Sorry.
tell us now?
Happened to my grandfather. He called my father's in Asala. It wasn't Asala at the time. And he says, I just shoveled the snow. I'm 6 years old and I'm not feeling it. He went through the system. He's like, you gotta get to the hospital. I'm calling Asala.
That's right. That's right.
Because you didn't shovel us now?
Okay.
The grandson-
Is it
Yeah, where was the
overexertion?
grandson?
Yeah, I was like 6 years
He
old.
was the
Overexertion?
grandson, didn't shovel us.
Yeah. So exercise, carrying heavy boxes, Pesach time and all these things, these are times when we see this stuff. But the thing here, what I want to point out, not alleviated with rest. Angina may be alleviated with rest. So with the angina patient, they may stop shoveling, come inside, sit down, relax, okay? And then 20 minutes, the whole problem may have gone away. The MI patient will not be any better, typically, all right? So again, these are all small signs.
So what relieves the pain of the MI?
We'll get to it.
Uh-oh.
Too long on the slide.
Yep.
So long as not.
Levine sign. Levine sign. This is Levine sign. This was developed by a doctor,
First crack.
one of ours, called Levine, and he realized that people clutch their left chest when they're having an MI. Yeah, it was called after him. It's still called Levine's sign to this day, and you see it. You will see it. I've seen it. Shortness of breath, this can happen. Yes, no, I don't find it to be very common. But again, I'm not saying it doesn't happen. It does happen. They have shortness of breath. May follow physical or emotional distress. These things. This is why you're going to learn to ask about what's going on in their life in general. Right? With a sample history. Right? Very good. What's going on in their life? What's going on? Emotional problems. Physical exertion, definitely. So, I want to talk about, I want to continue with signs and symptoms, but I don't have a slide on it. And maybe it's time I've had a slide on this, but just listen to me for your own knowledge. There are 3 groups of people who will have an MI and not have any of these signs and symptoms. Okay? Any regular person can have just one of these or multiple, okay? But there are 3 people that have been noted and very common that will not have any of the typical signs and symptoms. I want to make sure you understand this and know who these 3 are, okay? Number 1 are diabetics, okay? Diabetics may not have any of these symptoms. I'm not going into the reasons why, we don't have time. Number 2 are postmenopausal women. Okay? No, whether they're diabetic or not. Number 3 are the elderly. Men or women, doesn't matter. Okay?
These
So-
3 people do not have.
May not
So you have a
Show
female.
any signs?
show any signs of
So
symptoms.
that's like 80% of the people that have
So if
MIs.
you have
Okay.
a female, 58 years old, who's a diabetic, she's screwed.
Okay, so I once was called to a female, late 50s, and this was her symptom. I'm just not feeling right. That was it. That was it. That was enough for her to pick up the phone, or her son, daughter, whoever it was, and call Hatzalah. Okay? I came there, I assessed the situation. She had no history, no medications, no surgeries, no nothing. Absolutely 0 reason for her to need to go to the hospital. You know what her reason was? Well, she was female, and she was postmenopausal, and she was just not feeling right. And I made her go in, and we did labs on her, and she was having an MI.
How long does an MI last for?
What do you mean? Depends which artery gets blocked. They can drop dead within a couple minutes.
Or they can.
Okay? So these 3,
That's a judgment. That's a judgment call. It
Yeah.
could have been heartburn. It could have been
Yeah.
nothing. It could have been.
but you have to look at the entire picture. You have to look at a woman who is well put together in a house that is immaculate, that everything is perfect, and she's just not feeling herself. Okay? And she called.
It's bothered her enough.
Okay? She fit the criteria, I took her in.
Was there anything that you did on
No.
scene?
No.
Nothing you could.
I did EKG, I did
And?
nothing. Nothing. Alright.
Wow.
So we got the 3 exceptions to the rule. Okay? These are the 3 big exceptions. Okay? I also once had a male patient. I can't go into all the MI stories.
Tell us all.
Because I know, they want to go home. You want to go home in 2017 or 18?
Say better.
That's a once-a-year joke, and he nailed it.
So, 20 high we're going into, right? Alright, so,
You had a male patient.
So just one more quickie. Had a male patient, male patient who, let's say a family member of mine, 50s or 60s, let's say, in age, and came home from work early because he wasn't feeling right. Okay? This is a workaholic par excellence, okay? Like, never takes a day off, never stops, works really hard, and he just wasn't feeling right. And I did all the tests, I drew blood, I got ready, I did EKG, everything came back negative. Whatever I did was negative. Something bothered me about the fact that he was complaining. Like, he's not the guy that ever complained. And I said, you know, I want to let you stay home because you're a relative of mine. I feel bad to drag you to the hospital, make you sit there for 6 hours, one thing or another. But there's something bothering me. You got to go in. You just got to go in. He agreed. He agreed to go in. We took him in. He had massive blockage in 2 of his main arteries. And he had no symptoms. He didn't have any of the main symptoms.
Surgery?
Yeah, they don't do surgery. I'll explain what they
I know,
do
his
soon.
last name was Levin. No? What bothered you if you didn't have any symptoms?
The fact that he left work early and called Hatzalah.
Levine sign or something?
Levine.
All right.
Next.
No, I'm being serious. These are real cases.
You gotta go with your gut,
Yeah,
Or your chest.
not the monitor, the patient.
very good.
Showing up to be your best
I already
student,
learned
huh?
something.
Yeah, well, Izzy's an illicit, you know?
See, I see that. So who's stopping you from doing this more often?
Credit card bill.
Put it on your boss's bill.
I should.
Yeah.
All right. So what is the
With
treatment?
medical stuff. Huh?
Yeah, good one.
What is the treatment for us? We're in the field, we're EMTs, we got our bag, right? We got our stuff. By the way, what is the blood pressure of a patient having an MI?
250.
Just think about
What is the blood pressure of the MI patient? In one word.
Hi.
Low.
Hypertension.
Wrong.
Same.
Normal. Thank you. Right? Except for one special type of MI, which is called an inferior wall MI, which we're not getting into now, which would be low. Almost normal MIs, the patients will have normal, regular blood pressure that they would have. Why? Well, why is the blood pressure going to be affected? We have a blockage where?
And the
The
artery.
arteries.
Coronary arteries, right?
Oh.
Blood pressure is being read, the pressure that
Of the pump.
the blood is exerting on the wall. It's still pumping.
Well, unless it's if it's big enough that it's
That
affecting
it's
the pumping
killed
of the
part
heart.
of the heart and it can't pump anymore, yeah, that's going to be a whole different picture. All right? So I just wanted to throw that out. Monitor your ABCs. Obviously give high con oxygen, non-rebreather. Today, what we're saying is New York State is still saying just give oxygen. But now if you have pulse oximetry and they have an O2 of higher than 94, I, as a medic, will not give oxygen now for the MI patient. Okay? Your protocol is still to give oxygen. Place them in POC,
Position of comfort.
position of comfort. Okay? This is the patient that you can let decide how they want to sit. If they're more comfortable laying down, if they're more comfortable at semi-fowlers,
Driving ambulance.
fowlers, not driving, no.
Oh, yeah,
Driving ambulance.
this patient isn't cardiac arrest based function.
No.
Not cardiac.
Who mentioned cardiac arrest?
Sorry.
MI.
MI.
Blockage of one of the coronary arteries. They're alive, they're talking to you, they're fighting with you, they don't want to go to the hospital.
Why?
They've got these symptoms. Does it mention death here anywhere?
No.
No.
Why do you give them oxygen?
Why do you?
Yeah.
Oh, come on.
When in doubt,
You tell me why you give them oxygen.
When in doubt, oxygen out.
No.
Welcome back, Shruggy.
Shaggy, that's okay. But there's a much more intelligent reason. Ellie, come on. What's an MI? A blockage of?
Because your heart is.
Because there's a shortage of
One of the
oxygen.
coronary arteries, right? So oxygen is not making it where it needs to go. So if we increase the amount of oxygen that saturates the
Hopefully you can push it.
hemoglobin and something is getting through,
Push
it'll be
it.
highly oxygenated. Hopefully it will get to the end point.
So explain that a little deeper, so you increase.
So you're
the
trying to
amount of
push it
oxygen
through.
going in,
Right,
but there's still a blockage.
correct.
So hopefully
But
something
the
will
little
be-
amount that is getting in is now
Will
more
be,
oxygenated.
will be hyper, superaxionated. Now,
You knock it off.
why do we give, what else? So we request ALS, okay? But there's more we can do. We can give, according to New York State up here, we can give
Aspirin.
for aspirin, 324 milligrams, right? How do we give it?
Chew,
Chew.
Who said that?
No,
Chew.
can't.
Chew.
Chew like my God.
Chew.
chew, chew.
Chew them up, right? What is that going to do?
It's gonna go into his mucus thing and go straight.
What's it going to do? What is the
Oh, vasodilate.
No.
Aspirin?
No,
I'm sorry,
aspirin is gonna make the blood flow.
It's an
through
anticoagulant.
Very good. Almost said it right, Shrek. An anticoagulant. Very good. And it's going to
Grease the wheels.
prevent any more clots
From developing.
from developing and making it a bigger site, a bigger atherosclerosis,
Is that a
right?
blood thinner?
Anticoagulant.
Is that?
You just wanted to say
I said that
that.
before.
Google.
Now, let's say they have their own nitroglycerin at home and they have a blood pressure greater than 120 systolic and they have not taken any ED meds. You can give them
Sublingually.
one dose. How do you give that?
Under the tongue.
Under the tongue, one pill every 2 or 3 minutes.
Oh,
Here are
wow.
your contraindications again.
Go back,
It's got
Why are
gluten.
you skipping the New York City thing? Is that because it's not?
Because you need to know New York State.
Okay.
Okay? Angina pectoris means
Pain in the chest.
pain in the chest. Very good. What are the signs and symptoms?
Levine's move.
Same as the AMI. All the same. See?
Myocardial ischemia.
Except it'll go away.
May go away.
May go.
May go away. Can you know when you get to the scene, oh, this was just angina, stay home, don't worry about it? No.
Complaining about it.
No, you're going to the hospital. It's like, listen, it's like at the airport. You don't make jokes. Oh no, I have my bombs in the other bag. You know, you don't make jokes at the airport. In EMS, this is the same thing.
Hi, Jack.
There's no jokes about chest pain. Someone says chest pain, you confirm that it's actually their chest. That's taken seriously. There's no games. Okay?
Story?
So what's the
No, no, no,
percentage-
sometimes you just say
what
people-
percentage
people say, oh, I
of
have
chest
pain,
pains
they're
you
like,
get
oh,
there
it's
to the
hurting,
actual chest?
turning into
Go to the
inferior.
hospital.
Or let's say it hurts on the right
Say
side.
again?
What percentage of patients that describe chest pains and when you get to the patient,
Doesn't know.
they show the actual chest hurting them?
Oh,
Do you
most.
take them to the hospital?
Oh, they all go.
They're all loaded up.
They all go.
Load and go.
Absolutely.
Load and
Yeah,
go.
but if let's say they say the right side is hurting, if they say when you come
They're
in.
still going. They're still going. You can have an MI on either
What
side of
happens
the
if
heart.
the EMT say it was the chest and it's really the shoulder and the...
No, but the right side of the chest is saying.
When in doubt,
When you ask them,
Shruggy,
they show
we
you
can-
here.
Go, get a medic.
If you can't.
Takes a route.
What happened?
Takes
When it's happening, it's route.
Yeah.
Yeah.
Usually.
Go away.
Load and go.
Usually, but they still gotta go.
But yeah, I understand.
Okay? Listen. Treatment is the same. Angina treatment is the same as for an MI. No difference because you cannot make that diagnosis in the field.
So
You
angina
don't know.
pectoris is just a lesser version of an MI.
Right.
It's not as serious.
Well,
But it's the same.
it could be an MI, just have a less
It could be the
dramatic
beginning of an MI,
Cardiologist,
but
can you-
No.
it's the same thing.
It's
It's electrical.
But there's no way to tell except for those symptoms, and if they don't have those symptoms, it's still possible they're having it.
Yes.
There's the only way to tell is if it's
Labs.
surgery and lab.
No. First blood test.
And blood tests tell you.
Blood test tells you 100%.
What do they tell you?
It tells you if there's some enzymes called troponin And if that leaked from the heart because of the MI, they had an MI. Okay? What we do in the field, the medics do an EKG. 50% of EKGs will show the MI, 50% won't. Okay? So I had a patient just last week. Call came out around Myriv time, Arbit.
Perfect.
27.
I have to translate into Syrian. I get it. I teach in Flatbush, so I'm pretty good at.
He knows, it's the 5th time they get on the run. He's good.
Right, the fifth. Nice. Nice. In Flatbush, though, there's more of them than us, so I can't make all these jokes, but I have to be careful. All right.
So what happened last week? Yeah.
So I take a call. I take a guy out of Shoal, and he's complaining of
chest pain.
some chest pain, legit chest pain. He has a long history of MIs.
He's going in.
We get there, ALS, BLS, we get there at the same time. We put him on a chair, put him into the ambulance. I right away do an EKG, shows nothing. Okay? How's the chest pain now? It's gone away. Once he's sitting in the ambulance, no pain.
Angina pectoris.
No pain. So,
Angina.
yeah, you're thinking it's angina, right? Okay, no problem. This is on a Tuesday afternoon, evening, and in we go. Go to the hospital of his choice. No problem. Friday afternoon, I'm here, I'm walking in Shul in the mikveh somewhere, I bump into him someplace.
In the mikveh, probably.
Unless he was unremarkable.
No, a lot of times you really don't. You go so often, you can't tell
And
what's nickel and what's not.
I see this guy, and he comes over to me, he says, I want to thank you for the other night. I'd seen 1,800 patients since then. I didn't really remember, what exactly, So he tells me that he had a massive MI. He had stents, which I'll talk about in a minute. Stents put in, and this is Friday. He's already home. I said, wow, you're looking good. You're looking better. Yeah, he was very pale. I remember he was very pale. But that was it. He had no complaints at the time. The EKG showed a normal EKG. All right, and
Mucus memory.
you can't play games. Someone says they had chest pain. They did have. They go in.
What caused it when he got to the ambulance that he didn't have any pain?
Don't know. Maybe the rest. He was laying on the chair on the semi-fowlers.
3 days and you're out of the hospital.
Yeah, stents now are in and out. Yeah, drive-by surgery.
Over the counter. Can I get some cough drops and
And a stent.
What was that thing?
Would you like fries with that?
All right. So here's the treatment again. Angina. Your job, even though the state will ask you questions to differentiate between the two, but your job is not to differentiate between the two. Your job is to treat them all.
And have to diagnose.
Right. Treat them all as an MI.
So if they ask us what's the difference, the only difference is one that goes away?
Yeah.
That's the only.
Yeah.
So angina
So sides with rest.
That's why mikvah starts with MR. Both of them require.
Angina, we're calling for ALS.
Yes. Either way, you don't know if it's angina. That's the truth. Okay. Anyone complains of chest pain. And it's not the seatbelt that, got tight because they hit another car. That's not chest pain, okay? That's a pain in the chest. It's not the same as chest pain.
Ellie, you got El Paso, I got mikvah.
Good, as long as you remember it.
What's it called? But what if he has a history of angina? What if he tells you, I have angina, it's a normal thing, I just thought,
Yeah, you call, we haul. You call, we haul.
I like
He
that.
wouldn't have
I
called
like
if it
that.
was just a
Yeah.
regular.
If it was his regular
When
thing,
in
lasting
doubt,
for longer
get
than
the
usual.
route.
yeah, so then he's going in.
He's going in, that's
When in
it.
doubt,
That's it.
take the route.
No,
Bradley, you waste my time, I'll waste your time.
no, it's not like that. It's, you call me, I'm gonna save your life, despite your unwillingness, okay?
It's not only that. If once they call you, then they're your
Then it's your
responsibility.
responsibility.
If you let him go and then he drops, then it's your
Yes,
fault.
that's that
If
too.
he didn't call you when he drops,
Alright, just a couple more slides to go through pretty quickly.
Gorgeous. Gorgeous.
CHF.
I want to jump to acute pulmonary
What
edema.
about CHF?
Yes.
Listen. acute pulmonary edema is something you see in the field. Okay? Until now, the only thing you could do was to call for medics. Okay? There's now been a change in New York State, and you now have another option. Okay? So, acute pulmonary edema is exactly what it says. It's acute, it's happening right away. Pulmonary is in the lungs, and edema is fluid that is in the wrong place. It's a backflow, left side usually backing up through the valves, back where it came, which is from the heart. Acute pulmonary edema, how do you recognize it? So number one, they will have extreme difficulty breathing, okay? Number two, they may have all the signs and symptoms of an MI. They may have the chest pain,
What about lung sounds?
okay? Number three, when you listen to their lungs, you will hear something called rales. Rales is the swishing around of water or fluid in the bases of the lungs. Hopefully it's just in the bases, not all the way up, okay? When it gets all the way up, what happens is they sometimes have pink, write it down, pink frothy sputum. Did we put this already in?
COPD.
Okay? Now it's not COPD, this is in
There's 8.
APE. Pink frothy sputum. Now that can be coming out of their mouth due to the backup of all these fluids and blood and everything that's going on.
May have what? Say it again?
Eli, 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 you want a water bottle?
Frothy sputum. Yeah.
I got one.
Yeah.
Yeah.
Saliva?
Yeah.
It's foaming from the mouth? What? Sputum, saliva?
What's on Etsy? Should I Google it?
Sputum.
Now. Alright. Whatever. I still have a little ice in it. Thanks. There's a water fountain. I have ice in it.
Oh, I thought you said lice.
God forbid.
Rice?
Alright.
May as well.
Oh, we
Wait, is there a
added
buzz?
the slugs, huh?
Do you pause it?
Pink frothy.
Yeah. Yeah. So, okay, this kills people really quickly.
It's on the signs
Okay?
and symptoms though, right?
This kills people really quickly. So, with this you need to sit them up. You need to sit them up quickly. You need to put them on quickly on a non-rebreather mask. We're going to show you this new treatment called CPAP that's now approved for EMT use. And they will have very high blood pressures. I'm not joking when I say very high. Like you can see 260 over 140 high. Okay? High. Very, very high blood pressures. Okay?
How would you see that if you only go to 200 when you're doing?
Oh, because as soon as you go to 200, you would start hearing it bump. You're going to go up to 300. These are the people you go up all the way. Okay? You're going to have very high blood pressures. You're going to hear rales in their lungs. You may see frothy sputum coming out of their mouth. And you'll hear the rales, and you got to sit them up.
The water bottle.
Frothy.
Like the water bottle.
Yeah, right, like the water bottle that I showed you the other day. Thank you.
Where do I see the rails in your thing? You don't have any.
I had rails a few weeks ago. They said it was bronchitis in the lung.
You didn't have rales, you had bronchi.
She said it was rails.
She didn't know what she's talking about.
I'm getting my copay back.
Yeah, you should.
What,
Okay.
we should have rails in there too. no?
Yeah.
I miss CPAP, you know.
My father
What'd you
has a
say about
CPAP
CPAP?
machine.
We didn't get to it yet.
Hypertensive emergencies. I want to talk about this. This is very interesting. Okay? If there is nothing wrong with the patient except that their blood pressure is very high, right? They have no other complaints. They're breathing fine, their lungs are clear, they have no chest pain, just
High blood pressure.
high blood pressure.
They're the average American.
That's right. Go to the hospital. Don't call for medics. All right? 20 years ago, we used to give a drug to reduce blood pressure in the field, We found out later that we were killing more patients than saving because we were
great.
giving it way too fast,
That's great.
and it was actually harming many
Didn't
patients.
say anything about CPAP.
Because
So-
you weren't treating the underlying reason
Right,
for the high
we
blood
were
pressure.
just treating the hypertension.
A high 160 is an emergency already?
They go to the hospital.
Don't scare your
Are you serious? Oh boy. I better
Okay.
But why?
Because they called.
Give them Viagra.
They called you. And all that's wrong, you know, the Russians, they all call Davlenia. They have their home machine. They take the blood pressure, they get a crazy high number. Sometimes it's right, sometimes it's not. So you gotta check it. Okay? This is how it is. Okay? Blood pressure, high blood pressure.
Is that a test question?
No, it's not a test question. All right. High blood pressure. The time when it, there are times when it's really scary and will cause stroke. We'll talk about stroke on another day. Aortic aneurysm could be caused, and all these other nasty things. Basically, people should not have high blood pressure. Okay, it's dangerous in the long term, and if they call you and they have just high blood pressure, nothing else, there's no need to call for medics.
Load and go.
Load and go. If they have high blood pressure and they can't breathe and their lungs are filled with junk or whatever, that's APE. Call for medics.
I came up with a way to remember that. When in doubt, start en route. Boom.
Start what?
En route. Go to the hospital.
Oh, okay.
Alright, it was okay, Ari, it was okay.
You gotta sleep on it, but it works.
Yeah. Okay, so CPAP has now been approved for EMT use.
Where's my stand?
Right, you don't have it.
It's on an ambulance?
Yeah, EMTs can carry this now. Here, I brought one for show and tell.
My dad takes it wherever
For
he goes.
stay and play?
No, this is not stay and play ever. This is en route.
Why does my father not like wearing it? It's annoying, it's discomfort.
Sure, it's annoying and
Can't roll
uncomfortable.
over.
No,
Doctor
discount.
said roll
You could
over.
roll over, you could roll over, you just have to roll over on your left.
What is the CPAP used for?
AP,
What's
Rest on
APE?
your ear. And you
acute pulmonary edema. Look, this is how they're all slightly different, but they all work the same way. This one works, you put this rubbery piece
It looks like an
in the back of the patient's head. Then these 4 straps come around the front. This mask is put on the patient, and there are 4 hooks to put these onto. It needs to be on really tight. There must be a complete seal between the patient and this mask. That's why you have this to hold it, literally hold it on. Okay? Some of these need 15 liters of oxygen. Some of them use 25 liters in order to get this
But our
dial
regulars don't get
into
that high.
the 10.
How do you know it to go that high?
There's a dial tells you how much CPAP you're getting.
But
You want
our,
between 5 and 10.
our
to start
regulators
with.
don't get that high.
Right, so start with 15. These may work now with 15. Okay, here, you want to pass this around? Take a look.
But you
Okay.
can't use it
Can you put it
over
on
here.
someone?
Here.
No, the patient is conscious.
What is this connected to?
Oxygen.
What, but he's not, my father doesn't have an oxygen tank on the side of his bed, he has like a
No, he
gray,
has a machine
Sleep
that
out
generates
machine.
a.
a
You
gray.
give a kid albuterol at home, nebulize it.
Right.
You have a nebulizer
Right.
to
Similar-
generate.
similar size.
What's in here? There's a liquid in here?
No,
It's just
nothing.
nothing. It's just a spray.
Nothing.
Why is this mask better than a
Copper spray.
non-breather mask?
I was just gonna ask that, why is that, what's in,
It wasn't one.
CPAP.
He told me to stop it.
CPAP. So now it has been approved for BLS use. Until now, a patient in APE, you had to call for medics. We would come, put on CPAP, and give various medications in order to help this patient. You still need to call for medics, but you can get the CPAP up and running way sooner than, before we get there. It's very important that you understand this patient must be conscious. This is not like this that's showing the sleep apnea mask. This patient must be conscious must be breathing on their own. Okay? It's extremely uncomfortable. They will try to fight it. You need to talk them down, talk them into wearing it, explain to them that this is going to help them breathe. After 5 or 6 breaths with it on, they will be okay with it. All right? They won't like it, but they will feel the difference. And it's actually reducing the work for each breath that they have to take by giving them additional oxygen and moving the fluid out of the alveoli. It's a very good tool. We used to, before medics had this, we used to intubate all the APE patients. And you imagine that to intubate somebody, you have to lay them flat. What's the first rule I told you about APE patients?
Don't lay them flat.
Don't lay them flat, the water bottle, right? You gotta keep them straight up. So as a medic, it was very, very difficult, this decision to make. Because you had to be really quick, you have to lay them down, because there's no other way to intubate them. And you were always taking a chance, because you don't know what you're gonna see when you get the laryngoscope in there. Now, with CPAP, as long as they're conscious,
Keep them sitting up.
keep them sitting up, get the CPAP on, get a line, start giving them medications, and save lives.
Why
If they're
can't you use
unconscious.
this if they're not conscious?
Gotta be conscious. It's just one of the rules of the CPAP. You gotta be conscious.
If they're unconscious, you have an OPA in there.
Yeah, you have no PA and you bag them. And then I would intubate them.
Yeah, but like you said, the OPA, you're not gonna get the positive pressure.
Right.
Right.
So,
But you will with a BVM, or if you're
Yeah,
bagging them, you're still getting the
but
pressure.
not like this.
Not like this.
And you still probably have to lay them down.
Okay? Yeah, but if they're unconscious again
Right,
already,
but if they're
it's
unconscious, you put it on
it's
their nose,
easier.
and you may not be
Okay.
getting any air in.
Vents, many transport ambulances use vents. It is not a BLS skill, not something that's used in EMS, 911, Hatzalah, but it is used on transport ambulances. If you go to work or volunteer for one of these services, they will teach you about their vents.
But we don't use it?
Correct. Cardiac arrest. I have one slide on this. I will get to it in much greater detail on another night. However, there's a reason that I have this here, so I'm going to talk about it. When a patient dies, there are various rhythms that the medic or doctor can see on an EKG. Okay? When a patient dies, one of the rhythms looks like this. You see how it's just erratic? There's absolutely no rhythm to it, no size, particularly high or low. This is the ventricles quivering. Quivering is like this. Like if you take a plate of char or jello. I'm not sure how you say that in Syrian. Yeah, thank you. And you shake the plate, the jello,
Residual.
right? Not
But it's not-
residual, the
it's a-
jello
Yeah,
shakes.
It doesn't fit.
Jiggly.
It doesn't flatline.
Jiggly.
No,
That is a word.
that's later.
Oh.
Get jiggy with it.
This quivering, or jello as I call it here, ventricles quivering, this is known as ventricular fibrillation. Shortened to VFib, and that is also shortened to VF. Okay, so all three are used. The real word,
And what is that?
the real word is ventricular fibrillation, shortened to VFib, also shortened to VF. Depending on what literature you're reading, they could use any of these terms.
So patients in VFib,
Okay.
you got a shock.
Patient who's in VFib is dead. That's number one. Okay? And they need defibrillation. You need to stop the
Death.
fibrillation, the quivering. Okay? So understand, when you use an AED, and we're going to do a whole lecture on this another night, but when you use an AED, okay, you are not jump starting the heart like a dead battery in your car. It's not what you're doing. You are stopping the heart. Okay? Whenever you use a defibrillator, and again, I will explain this more, and you're going to use it in skill labs. the heart is doing this. You need to stop that and hope that it goes back into a sinus rhythm. Okay? So if you see this on EKG, this is one of the types of death. That's why we have this guy here, right?
He's happy
Ari.
or sad?
Oh, that's what he is?
Yeah,
Is he happy or sad?
Depends on the patient.
Well, it depends if you defibrillate and do CPR.
Still be sad.
Okay? This patient has no pulse. And this is the earliest, most common form of death that people go into immediately. Alright? People generally go into this for a short amount of time, then they go into something else called flatline later. Our job, that's why we exist, is to get to the patient while they are still in this rhythm.
How long does that last?
How high is a Chinaman?
Pretty short.
That's a statement.
Right,
What is that? Not me.
right.
Okay?
What is that?
Yeah.
We had the brownies.
How long can it last?